moving on now to our second keynote address, and I'm sure needs no introduction. Ellen Webber, the editor of the EMJ and professor of in the University of California, with also a wealth of experience in global events and global research worldwide preceding that.
Hi, good afternoon, and thank you for rejoining after lunch. I hope I will keep you awake. I know lunch hour, post-lunch is always a postprandial nap, so we'll try not to have you fall asleep too quickly, at least. So this is going to be a pretty practical lecture, a little bit of inspiration, but mostly I actually want to give you some advice on how to do research so you do it well. But I'm talking about the kind of research that should be pretty feasible even without a lot of funding. Now, that's not to say that emergency medicine studies shouldn't be funded, but you all know, and it's getting worse, that the funding situations are difficult in emergency medicine in particular. You know, we don't have a niche a lot for our work. So I started out, and actually most of my work has been unfunded. But the point is that it can be unfunded or minimally funded, but it still can be high quality. And that's the thing, you don't make excuses just because you didn't have funding. So, so there are a number of barriers to research, and actually some of these will look familiar to you because they're the same barriers we see in high-income countries. There's the cost. There's a difficulty with the research infrastructure. Some places don't really have one. They don't really understand the concept of research. The IRBs may be slow. Funding sources are difficult to find in low and middle income countries. And now, you know, high income countries have been funding a lot of studies. And you know, unfortunately, that my country is backing off on that. Then the other thing people don't talk too much about is that people who work in low and middle income countries in general do not get protected time to do research. So even if they get funding for a grant, they're needed on the shop floor. And so they're going to always be competing with clinical responsibility. They can't buy down their time. Then there's the resources of just, you know, if you wanted to do a chart review, you wanted to look at referral notes. They're not always complete. They're hard to find. Many of them are still on paper. So that can sometimes be a limitation. And then the other thing is simply the time. How much time do you have to spend on the ground versus the person, hopefully locally, who is spending more on the ground, and your stamina for completing research. And all of that is across the board wherever you're doing research. So what we look for are studies that take a little bit less of all of that. All right, let me go forward. There? No? No, next. Previous. Oh, hang on. I got it. Okay. So just before I finish, start the rest of this, disclosures. I don't have any commercial disclosures, but I do want to say I never started out to be a researcher, and I never started out to be a global health person. And now here I are one. And it all happened by accident because I said yes to going to Tanzania to do 2 months teaching emergency medicine when we had a grant to go over and help in the first emergency medicine residency program in Tanzania. And they needed clinical faculty to come and for the first couple of years and to teach. And so I said yes, and I was there for 2 months. I loved it. They loved me. Turned out that I was able to help them with some research, and I've been going back ever since to teach research. And on the way, I have learned research. So it doesn't always have to be, you have to get that PhD first. You learn a lot by doing. Oh, okay, that's where we went. Okay, so now, so this is one of the various models you see of the research hierarchy and the strength of evidence. And at the very top, we have evidence synthesis. At the very bottom, we have basic research, and above that maybe like case reports. And somewhere in the middle here, we have prospective and retrospective pretty much observational studies. They are not at the tippy top of the evidence pyramid, because we like evidence synthesis and we like RCTs, but those are hard to do. I mean, evidence synthesis, yes, but they're hard to do well. And randomized controlled studies take time. They take people being willing to enroll patients for you. There's often a lot of fallout because people don't consent to being randomized and so forth. So a lot of where you're probably going to want to start is with the prospective and retrospective studies, observational studies. Now, as you see on the pyramid, as you go higher in the pyramid, there's less bias. And bias doesn't mean prejudice. It means systematic error that is coming into your work. And it could be in the way you select patients, enroll patients, the way you collect data, the way you analyze data. And that is what we try to avoid in any kind of research. And particularly observational research does have a lot of risk of bias. So what we're going to talk about today is how to do good observational research, retrospective or prospective or both, okay, without a lot of bias. And there are rules for this. I'm not going to be telling you anything that isn't already out there in the literature, but hopefully giving you a couple of tips on how to do this in a practical and feasible way. And one other thing, Lee Wallace mentioned this morning, all of those checklists that WHO once tested. One way to test those is to do basically a before and after study. It's not randomized. You can't take one hospital and give it the checklist and have it fix itself and the other would not. But you can do in your own hospital or any hospital, you can look at the before situation, maybe with a retrospective study. You can look at the after situation, maybe with a prospective study. And then I'll show you at the end how you can make that a high quality study to prove that in fact, whatever you did, whether it was using the WHO pre-hospital checklist or whatever, made a difference in care. So it all fits into a lot of what is needed now in research in emergency medicine, particularly in low and middle income countries. All right, sorry, I went the wrong way, okay. So the point here is it's not just about the time and expense, but observational studies are not a compromise. Don't think about it that way because you can't do an RCT. In fact, we need observational studies and we need these improvement studies because in low and middle income countries, there's a lot of information that they have that we don't. Diseases present differently, they have different etiologies. This is what I saw in my first week at Mullumbila Hospital. On the left is a small bowel obstruction in a young person who had no prior surgery. You know, in the high-income countries, prior surgery is probably your biggest risk. This was a person who had not, and that has to do, as I understand the physiology, with just a lot of lymphadenopathy from diarrheal illnesses early in life. It is a risk factor, but it's not the only risk factor. Hemorrhagic stroke. We always think, you're always told in the textbooks that ischemic strokes are 80%, hemorrhagic strokes are 20%. Not at Mullumbila, at least half of them were hemorrhagic strokes. And that's due to probably the high incidence of uncontrolled hypertension. And so one reason is we need to know about what the disease looks like in those other countries. Another reason that we need to say what diseases are in those countries is what funders are going to fund. We need to tell them what it's important to fund. And right now, donors are funding malaria, TB, and HIV/AIDS for the most part. Okay, that is where the bulk of research money is going. But where is the disease now? Diabetes is increasing, hypertension, cardiovascular disease is increasing, neoplasms are increasing, and mental disorders are increasing. And there is very little funding in these areas. So we have to prove that these things are issues because they are. When I was in Mullumbila, other than trauma is another one, we saw some malaria, but mostly what we saw was hypertensive crisis and DKA. Okay, and and congestive heart failure and kidney disease. So first world problems are coming in. That's weird. Sorry, one of my slides, several of my slides didn't show up. Okay. Now the other thing is trauma, and trauma is a very big issue in low and middle income countries, and yet it gets very little funding. And you can see injury at the very top gets 4 cents on four US cents for every disability life year, compared to malaria, TB, HIV, and maternal and child health, which gets a lot more. And so you can see, though, that trauma is still a major cause of death in these countries, and yet there's very little funding for it. And then we also need to worry about the quality of our care. What are we doing out there? In many countries, they've rapidly scaled up emergency medicine in kind of the high-income model, but not totally. But what they need to know now is how are we doing? How are we doing in these places, particularly where we've built emergency departments, but we don't have emergency medicine specialists? So for the many reasons, therefore, we should be thinking about observational research, not just RCTs. But research in limited income countries can be feasible, it can be useful, it can be done as part of the daily job, and it can be done rigorously. So here's a couple of general principles about how to keep the costs low and the quality high. First of all, if you're thinking about doing an observational study, think about something that you can have a lot of patients quickly. So that might be a survey of all your patients. It might be a survey of all your staff. Everybody's eligible for your study, so it goes quickly. Think about doing things like prognostic studies of a tool such as the News Score, the DIVA Score, where again, all the kids who come in are eligible to see if the DIVA Score works in that country. Because we've developed a lot of these things in high-income countries. We don't know if they work in low-income countries. Think of something that's a common disease. So yes, malaria, maybe. Trauma, yes, it's common. Pick something that's going to come into the ED frequently, or which, if you have looked back at the charts, there'll be a lot of. And if you want to do something with quality, okay, you could look at quality of care for a particular disease, but you can also look at things like documentation for everybody, medication for everybody. So there are things where you can think about how soon can I enroll everybody in my study? And preparedness is another one, finding out how well, again, looking at the WHO checklist, are these departments ready for disaster, for children, for whatever. Data, if possible, you want to try getting data that's routinely collected, already exists, or it can be obtained relatively painlessly. And then you want something that's going to bring enthusiasm from your colleagues. So you're doing some research. If you want them to help you, it should be something that they're going to be interested in, like decreasing crowding, making their work easier, decreasing complaints, and so forth. So something you can get buy-in, and everyone's, yeah, we're gonna help you get this study done. Sorry, I keep going the wrong way. So let's talk about the different kinds of observational studies you can do. Basically, I break them down into two: retrospective and prospective. Now, there's a lot of in-between cohorts and so forth, and I'm not going to get into that. Doesn't matter. When you design your study, you'll figure out whether it's a cohort or case control study or a cross-sectional study. Retrospective studies are great because they're inexpensive, the data's already there, the outcomes are already available, so it can be done relatively short term, and you can get large numbers of patients, and that's particularly helpful if you're looking at a rare disease. But they have a high risk of bias, and a couple of the bigger sources are case finding. You want to do some research on a if you want to do research on abdominal pain, how do you do that in a retrospective chart review? Because people are going to have a diagnosis in the log, right? They're not going to have abdominal pain as their diagnosis. And oftentimes the chief complaints are not kept. So how will you find the cases that you want? Okay, suspicion of MI. How would you define suspicion of MI or chest pain? So we have the same trouble again in our own research, and what we often have to do is something like look for multiple diagnoses, or if you have, get a way in which you can access chief complaints, that would be better, or pick a diagnosis and stick with that. Missing data, big problem in retrospective research. We all document a little bit differently, where many people leave things out. What do you do if something's missing? You don't know whether or not the person had rebound tenderness. So we don't always have all the information, and then you either wind up excluding those patients, which is a form of selection bias, or you make some guesses, which may be a form of information bias. So that's a risk also for retrospective studies. And then there are problems with interpreting the chart, where your abstractors are asked to decide what the doctor thought, which is not so easy to do. Or they're aware of both the patient's presentation, whether they got medication, and their outcome. And so if they're, know a little bit about the hypothesis, they might interpret a chart in such a way they go, well, this person got this medication, so they must have had this disease, right? So they can be subconsciously influenced. So you want to kind of separate out those kinds of issues, so they're as blinded as possible to some of those issues. Now, prospective study is great because you can collect whatever data you want. You can make things required, and you can get things that are not normally collected. And one of the things that people talk about a lot in limited-income countries is delay to get seeking care. And yet you won't find in a chart how long it took a mother to bring her child to the hospital. You have to ask them that question. They won't tell you whether they went to a traditional healer. You'll have to ask them that question. So that's the kind of thing when you want to find out, why are people coming in late, that you would want a prospective study for. There's clearly less missing data because you can sit there and ask that question to make sure it's written down. And it's aligned a little bit more with the ED perspective because you can enroll people based on the chief complaint rather than on the ED diagnosis at the end. Disadvantage are, it usually requires patient consent, so that's a little bit of a hurdle because somebody's going to have to consent that patient at 2 in the morning. It takes time to get the desired sample size. Getting the data collected is a challenge. Will the physicians or the nurses complete the forms? Can you afford a research assistant? Well, actually, it turns out you often can. And what will you do if patients are missed? Are they missed at random? Okay, for example, one of the things we see in ultrasound, prospective ultrasound studies, is that you have X people with abdominal pain, but only some percentage of them got an ultrasound. And then you want to determine the accuracy of ultrasound. Well, providers may pick certain people to do a bedside ultrasound because they don't think they're going to get a good study on somebody who's very large, for example. So you may wind up with some selection bias there because the person, those patients who couldn't have been scanned or would have had indeterminate scans are not in the study. Another possibility, though, is something like you want to do people who had a blood gas. Well, maybe the blood gas machine breaks periodically. Well, that's more likely to be at random, and so that might be something you can forgive. Okay, and then there's a problem of selection bias if you can't enroll 24/7. What do you do about people that come in at night? So before you get started, a couple of things to ground you. One, make sure you know approximately what kind of study you're doing. So it's observational. It might be a strobe would be the research checklist you would look for, and that's on the Equator website. And at the end of this, I have some QR codes for you to find these things. And so strobe is sort of your right-hand man for most of these kinds of studies. And records is taking you through how to do a chart review. I highly recommend reading one of these two reviews that appeared in the Annals of Emergency Medicine by Gilbert or Kaji, which are about how to do retrospective chart reviews, because they really are exactly what you need to know to avoid bias. And so when somebody like me gets your paper at a journal, we say, well, what did you do about this? And what did you do about this? And they will explain why you need to explain those sorts of things. Obviously, you need IRB approval, you need humility, and you need patience. And importantly, I want you to remember, this is not your study, okay? You are doing this work in another country, hopefully according to what those people in that country, the local investigators, local physicians, feel they need to have work on. What questions do they have? So be led by local needs. If possible, I know you're young and you want to get a first authored paper, but try not to be the first author. Be the senior author. Yeah, you can be the senior author. It's okay. Okay, I know you're all young, but you can still be the senior author. Think of yourself as your capacity building with this knowledge, a little bit of knowledge maybe that you're just gaining from this one talk about how to do this work well. And what you're there for is to help that person, that department get better at research so that they can then go on and do research without you. You basically want to replace yourself. You're mentoring, you're helping, and you're part of the team. Okay, so I'm going to take you through kind of a little thought experiment, how we're going to design a study that's feasible, that'll have impact on the care we give, and can be done in a limited income country. And research is often driven by a problem. It's one way to get people interested in ED when they're busy. You go, what problems do we have? Oh, we have a lot of problems. When you say research, they go like, oh, we don't have time for research. But we do have to solve problems, so it is part of our job. So in the hospital I worked in, the team said they were concerned about the patients who came in with trauma, that they weren't getting pain medications, because people in Tanzania are very stoic, and they don't ask for pain medicine. But yet several people had walked through the department, and somebody had quietly kind of grabbed their hand and said something about pain. So they wanted to know if people are getting pain medication, because if not, they wanted to be able to fix that problem. So trauma is a very big deal in Africa. One of the reasons you can see here is that there's a sort of a lack of helmets on motorcycles. Sometimes the people you're seeing, these are what's called boda drivers, and they are basically taxis. And they have helmets, but their passengers do not. They sometimes carry a helmet for a passenger, but the passenger doesn't wear it. And this is the source of a lot of trauma, particularly head trauma that we see. So you decide to do a retrospective chart review on people who get pain, whether people are getting pain for trauma. You know the data's already there, you happen to have pain scores being collected at triage, and you want to do this kind of quickly because you think maybe you're going to have to fix something and then measure again. So we're going to want to do this as a retrospective study, and you know you have a large number of patients that you can get this way. So we're going to do a chart review, okay? And these might be my outcomes. Did they get a pain score at triage? Did they get pain medication? If they got a pain score. Did anyone check that they were out of pain after they got pain medication? And did the medication they were given, did it match what they should be given? And that's a little trickier. So let's talk about some of the challenges. So patients in my hospital are coded according to diagnosis and not, that got in the way, and not their chief complaint. So how do I find these patients? They're not going to have a diagnosis of trauma, right, in my retrospective chart review. What am I going to do? Thoughts?
Prospectively see the coding process in action, so that if you
So that's why you want to do a prospective study, right? If you can. But I want to get some data out to my people to do that, get them interested in doing it. So just think about it. You might just look for a bunch of, it doesn't matter in this case that you got everybody, okay? Let's say what we really care about is, by the way, you can make this argument, okay, in your manuscript. What we care about is people who had fractures, okay? I do not care if somebody had an ankle sprain. I'm not worried if they got pain medicine. But I really want to make sure that everybody who had a fracture, okay, that's going to be an ICD-10 code, okay? So I can just say I'm going to limit this to people with fractures. So you just get creative and have a rationale for why you did that, okay? Okay, now what if there's no pain score? How would I be able to judge if they have no pain, if they needed pain medication? Again, because I'm relying on saying, okay, they have a pain score of 7, they should have gotten pain medication. But the nurse forgot to chart it. What do I do in the retrospective chart?
If you look at injury severity scores.
Yeah, I can look at their injuries in some way. An injury severity score would be a good way to do it. Exactly. So you're going to use some proxy in the chart of something that was charted, that is usually charted. So you can consider the diagnosis, like I said, fracture. You know that's painful. But having a score of some other kind would be fine too, okay? Or seeing that the patient, reading the chart, that starts to get to a little bit of judgment, which we'll talk about in a minute. So, but again, you can think about, how do I get that information? Because I don't want to exclude everybody who didn't get a pain score. I happen to know in this hospital everybody got one, but if I didn't, I'd be excluding many of my patients. Now, assessor bias, so now somebody's looking at the chart, and will they interpret the chart as most of us would? About the need for meds, ISSS, for example, if they write it. Does everybody chart the ISS exactly the same? Probably not, especially from a written note. So when you do a chart review, you want 2 abstractors, okay? This is really key. And you don't have to do all the charts, but at least they should do some charts separately, but overlap on some, okay? That is really key to making sure you don't have that kind of bias. And then, as I mentioned, if they're aware of the presentation and the outcome, you can also have assessor bias. Person got pain medicine, so they must have needed pain medicine. Okay, can't do it that way. So you may want to blind them to whether or not they could look at the nursing notes to see if medication was given. Okay, and then who decides if the medication is appropriate? Well, you can have an expert panel, but that takes a lot of people to come up and say, well, let's read the chart and see if the ISS is high enough or so forth. Or you can use the WHO checklist, which actually tells you, again, on the type of pain, based on the pain score, whether they should have gotten opiates or whether they should have just gotten steroidals or paracetamol. So all of this keeps you honest, keeps you very objective. All right? So we're doing all that. Now, how many patients do I need? Well, that's another one that can be tricky. You could do a sample size calculation, but you can also use a pragmatic sample size. You can just say, hey, we went to electronic charts 2 years ago. I'm going to do 2 years, okay? Not perfect, but good. Okay? How much time do you have to go through the charts? How much time do I need? So that's what you say. This was we did a feasible study. It was feasible for us to do 2 years of charts. And were there any big changes that might be a time, okay, 3 years ago we got a CT scan, and so we have more diagnoses now, okay? That's where you start, because anything earlier probably doesn't count. So you can come up with a reason, you're not totally fudging it, but you are coming up with some way to explain why this feasible sample is also representative of what's happening right now. When you sample, also remember seasonality. So if you think about, well, I'd like to do, I don't want to do just 6 months. I probably want to do a year. Okay, if I don't have time to do a year, maybe I do 1 month for 3 years. So at least I'm looking at the same period of time over time, right? Rather than having a winter and a summer. Then I know things haven't changed. Okay, now what if we want to do this prospectively? So the advantage here is we can see the patients as they come in and go, trauma patient, enroll, trauma patient, enroll, okay? Maybe I only want to, screen people who come at a certain time of day, but nevertheless, I can pick it based on how I can find the patient based on chief complaint. I'm less likely to have missing data, right? Because I'm collecting data on the spot. I'm asking the patient, I'm asking the doctor. I'm obtaining, information that may not have been collected. Did they wear a helmet? Maybe they didn't. How did they fall? Do they normally wear a helmet? Or just this one time they didn't wear a helmet? Okay. And we can also make sure everyone gets a pain score. If we do it prospectively, right? We make sure they actually have a pain score documented, so we don't have to worry about the ISS. So there's some real advantages here. And we can even ask the patients, did they ask for meds? Or did they refuse meds? Because that's one of the reasons they may not have gotten meds. We won't know that for a retrospective chart usually. And you could even do a patient satisfaction survey. You can go crazy with a prospective study, but you have a lot of hurdles. One is consent. Patients in severe pain may not be able to consent. What can you do? Exclude them from the study? Anyone here have an emergency waiver of consent? A couple of people. You have it. You have it here, and most places have it now. You basically get the IRB to approve you enrolling people in the study when they're not able to consent, and when they are able to consent, you go back and ask them for permission to keep their data in your study. Great thing to do, okay? And it was designed for emergency medicine. Will you have enough patients in a reasonable time frame? If necessary, you can expand the remit. So I said fractures. Well, now I can do trauma, all trauma, because I don't have to worry about finding the case, okay? Or maybe I want to do all pain, any abdominal pain. I can keep adding in things that I want to study because I'm doing this prospectively. Who will collect the data? That's probably the biggest barrier. So it turns out, like at least in Tanzania, research assistants were very inexpensive. They were the least expensive thing we had. Medical students will do it, nurses will do it, very low rates. It's just a low income country, but it was very feasible. But you can ask medical students to do it. You can ask collaborators, so you have collaborators on your study, to rotate coming in on their days off. So you can collect the data that way. And you can have what's called automatic data collector. You do something so the doctors themselves create exactly what you need. And so one thing, and you have a lot of these already in your own EDs, you have pro formas, which are filled out for any particular complaint, pathway. Or you use an electronic chart that requires people to put things in, and so they can't get around documenting. And this is documentation for clinical work that they're doing, but it's also going to go to your research study. So this is an example of what they did at Mohambili many years ago, before they had an electronic chart. They designed a data collection form for trauma, and they put it in this giant book, and it had NCR paper, so it had one big data sheet, an NCR paper, and a copy below. One got ripped off and was sent with the chart to the patient when they went to the ward, and the other one was brought over to the dated people who entered it into REDCap. Very clever, huh? Yeah, they did a great job. That book cost $12. 50 patients could be enrolled based on that. And the doctors did it because it was the only charting they had to do. It told them exactly what they needed to chart, which they loved, right? They like being told what to chart, no free text, okay? One thing to know, though, is if you want to study how good documentation is, this won't help you because you'll just force good documentation. Okay. Now, sampling is an issue with prospective studies. You want to do consecutive sampling, but sometimes you can't afford to have somebody collect data all the time. So what you need to do then is is basically representative sampling. So have people come in on alternate day and night shifts. Okay? Do not leave out the night. That's a real problem for selection bias. We all know different patients come in at night than during the day. We've all been there. So use representative shifts. Also track anybody who might have come in the day before, if you have a trauma log or something, and see if you could find them on the ward and enroll them. Or at least record the basic data, age and sex, so you can compare the missed patients to the ones you didn't miss. All of these things are going to be looked for in your article about whether people you missed are the same as the people you didn't miss. And so we did this study at Muhimbili. And this is Dr. Dunga, who unfortunately passed away last year at a very young age from pneumonia. But he did a prospective study on whether or not we gave people pain medicine for trauma. And you can see that we actually did a pretty good job of giving people pain medicine when most people who had severe pain got pain medicine. And then he even checked what they did, what kind of medicines they got, and we used the WHO checklist to decide whether that was appropriate. So we didn't have an expert panel, we didn't have our research assistants decide up from the chart. We used objective ways of marking that. Okay, so finally, now I've shown you how to do this retrospectively and prospectively. Now, I'm putting this together, we're gonna do an improvement study. I collected that data retrospectively, right? I should now share it with my department. And they go, oh, no, people aren't getting pain medicine. We ought to do something about that. Yes, you should. We should. So let's come up with some intervention. And then you have a whole meeting about what kind of interventions you could have to make sure people get pain medicine. Should we have a proformer? Should we have somebody checking on us? Is there a required field? Pain medicine, you have to say yes or no. Then we execute that intervention, and then we measure again. So we did the retrospective study, we saw how much pain medication was given. We do an intervention, and then we do a prospective study to see how we did. And a couple of things to think about. This is not a randomized study, so you have to be worried about confounders in the before and after period. So you have to count for confounding in the before and after period. So maybe more people got pain medicine, but maybe there were more nurses. Maybe there were more trauma patients. Maybe the fractures were worse. So you have to make sure you have the same case mix, same number of patients. Was there anything changing beforehand? Did you have, were people already getting more pain medicine before you put the intervention in? And did the change come with the intervention? And then you show something like this, which is kind of a timeline, and you can see here's my intervention. Things were not really getting better beforehand, and then they were getting better, at least for a while, after my intervention. So that's the kind of data you need to collect. So you need to have this before data, preferably in what I call an interrupted time series or an SPC chart, however you want to call it, and then capturing it, say, every month or so for the next 4 or 5 months, preferably even after you stop watching, so we know that this change was sustainable. And that's all I want to say. This is my email. So I want to thank you for your attention. Up here are a number of resources I mentioned that I would like you to consider. They're brief to read. None of them are big textbooks. They don't require a whole course. I think you'll find them helpful in doing this kind of work. Thank you.